Good afternoon and welcome to this public meeting of the Standing Committee on Social Development. My name is Jane Wayellen Armstrong and I am the MLA for Montpelier and Clichy Region and Chair of the Standing Committee on Social Development. I will now ask the member in the room to introduce themselves for the record.
Oh, sorry. Hi, my name is Julian Morse, MLA for Frame Lake. I don't sit on this committee, but just here as a guest. Thanks.
Good afternoon. My name is Danny McNeely, MLA for the Sahtu. Welcome.
Good afternoon. I'm George Nearsu, MLA for Mackenzie Delta. Welcome.
Good afternoon. MLA for Great Slave, Kate Reed. I am an alternate to this committee. Thank you.
Hi, I'm Shauna Morgan. I'm MLA for Yellowknife North, and I'm a member of the Social Development Committee.
Okay. And for the member online?
Hello, I'm Kieran Testart. I'm the member for Range Lake.
I'm Cheryl Yakla. I am the member for the DECHO.
Okay, thank you, members. Today we are joined by officials from the Department of Health and Social Services to receive a technical briefing on extended health benefits. Please note this meeting is being live streamed to the Assembly's social media channel. I would like to remind all members and witnesses to direct all questions and comments to myself as chair and to wait to be recognized before speaking to help us have a smooth meeting. I will now pass it over to our witnesses. Please introduce yourself and proceed with your remarks and presentation. Thank you.
Thank you, Madam Chair. My name is Jeannie Matheson, and I'm the Assistant Deputy Minister with Finance, Policy, Planning, and Communications for the Department of Health and Social Services. And with me today, I have Assistant Deputy Minister for Corporate Services and Cultural Safety, Mr. Perry Heath, and Stacey Ridgely on my left, and she is the Director of Policy, Legislation, and Intergovernmental Relations. And joining us online, we have Nick Saturnino, who is the Director of Health Services Administration for the department. So I can get started and move right into our presentation. We're happy to be here today to give an update on the new extended health benefit policy. And so we'll keep it to a short presentation and then leave time for questions at the end. There's no light on, is that okay? Oh, it's over here, okay.
Click for you?
Sure, if you want to click, that would be great. So today we're here to give an update, just an overview of the current extended health benefit policy, more as a refresher of what the policy currently is and what the policy is moving to come September 1st when we're planning to implement the updated policy. And so the current policy, it is a policy that provides extended health benefits for non-insured services to residents without access to any other insurance plans. That's the focus of the supplementary health benefit. So residents with access to non-insured health benefits or Métis health benefits and employer-sponsored plans are not currently eligible for the extended health benefit policy. Residents currently with a specified disease condition that's on the list of specified disease conditions under the policy are eligible for benefit, as are seniors who are defined as residents 60 years and older. So seniors have access right now to a range of benefits, including drugs, medical supplies and equipment, some dental treatments, medical travel, and some coverage for vision eyewear. And people with specified disease conditions currently are eligible for prescription drugs and medical travel in some cases as well. So that's our current policy. It's for seniors and people with specified disease conditions. And why are we making these changes? Well, this policy has not been changed in many, many years, and currently we don't feel it's a fair policy. It's currently focused on providing benefits to a very limited number of residents in the NBT, So those with specified disease conditions, and as I said, like that list of specified disease conditions is very limited. So there are a number of people with many other health issues that currently can't access the benefits, and seniors. So we would like to focus the policy, make it available to more people. And yeah, that's mainly the main reason, and to have a sustainable benefit program so that, you know, with just the costs of benefits, the cost of drugs and medical equipment and supplies, et cetera, increasing annually, it's also a priority for us to make sure that we can keep pace with that. So if legally challenged as well, like we've determined that we have the possibility of being found to be discriminatory in who we're providing benefits to, just because it is limited to such a very small subset of the population. And we are moving to a fair system where people who do have some financial capacity to contribute to the drug costs do so. Just a little bit of background on why we're making these changes, because, you know, we have been working towards these changes for a number of years. Work began as early as 2003 when we highlighted the inequity in the program for residents of the NWT. And despite a great deal of work and 2 attempts to come forward with changes previously, we were unsuccessful. The issues identified 20 years ago continue to be the same issues that we're facing here today, is inequity and who can access the program, and just the ability to keep pace with the costs. In about 5 or 6 years ago, this program is an expensive program, and we are regularly going back to the Financial Management Board for increased funding for this program. About 5 or 6 years ago, when we went back, we were told that we needed to do a review and figure out how we can make the program more sustainable. And so that work has been, like, more significant work has been underway since then. In 2020, we had a plan in place, a plan to propose, a planned approach, but it kind of got a little bit sidetracked, a lot sidetracked, because of the pandemic. And so we picked back up again when we got back to business, and here we are today. So what is actually changing? Residents will not need to have a specified disease condition in order to be eligible for benefits. And that's a big thing. It's anybody can access benefits. The change is also we're adding an income assessment process to determine eligibility for benefits. So residents with low income will have access to all the benefits, which are drugs, medical supplies and equipment, vision care, dental, without any cost sharing arrangement. There'll be no contributions required for those residents. And residents above the low income threshold will have access to drugs and medical supplies and equipment benefits, and there will be a cost sharing arrangement with family maximums to the limits that they will have to pay. Currently, no plan changes for seniors. And just a reminder that these changes do not impact anybody that are accessing Métis health benefits or non-insured health benefits. Okay, next slide, please, Stacey. So the main details here are that there will be an income assessment process, and what we're planning, and it's, you know, well underway, all that planning, because we're coming live here September 1st, is that there will be an application process, and through that process, residents will provide their tax information from the prior year, and that tax information will be assessed against a set of income thresholds, which have been set by regional basis, and they will fall somewhere within a band of incomes, and then that will determine their eligibility for benefits, including how much they will have to contribute, and what the family maximum is as well that they have to contribute for any given year. The income thresholds, our plan, we've set them now, we've just got them finalized, and we're planning to publicly release them here in the coming weeks. We're just actually in the process of going through a translation process for them, so they'll be posted online here imminently. But each year we will be adjusting the income threshold, and it's based on the market basket measure. And after we've done a number of consultation processes leading up to this point, and one of the things we learned during those sessions was that it was important for income thresholds to be representative of regional buying power. And so we have implemented in our process distinction between regions for the market basket measure. So just to clarify a little bit more around the income threshold, so they will take into account family size as well as region. So and adjusted. So the bigger your family, it will impact the amount of benefits that you're available to access, and the region, like I just spoke to. And the way that we have the income bands set is that there's 30 bands in our current, for this year, and the amount that a resident will have to contribute to the benefits, this is specifically around drug benefits, the amount that the resident will have to contribute increases a little bit, the higher your band increases, the higher your income goes. But at no point, at the max of the thresholds, at no point will a resident ever have to contribute more than 4% of their income to the cost of their drugs. The way the drug benefits work is that, like I said, residents above the low income threshold, under the low income threshold, no costs. Above the low income threshold, they will pay a deductible. And that deductible, again, is dependent upon your income threshold. And they will pay 30% of the drug costs, up to a family maximum. And medical supplies and equipment is the other benefit that is available to people that are above the high income threshold. And they as well will pay 25% of the cost of the medical supplies and equipment, and the government will pick up the 75%, again, up to a family maximum. And right now those family maximums, depending on the income threshold band you fall in, the most someone would pay would be either $500, $1,000, or $1,500 for a year for medical supplies and equipment. Next slide. This is just a visual here of the way that we've got the new policy set up. And previously, what would have been on this slide would be specified disease conditions and seniors. And it would we've kind of laid it out here so that to represent that these benefits are available to everybody, regardless of your specified disease condition, and it just kind of presents it a little bit differently here. So this is just a summary of what I've just said. Next slide. So we're in the process of implementing currently. We had initially planned to have this work implemented for April 1st, but it did get pushed to September 1st. Things got delayed a little bit with our third-party administrator. There was a number of system changes that had to happen that it was just going to take a little bit more time for our contracted service provider to implement. So that has pushed us to September 1st. We are expecting that residents will be able to apply for the benefits come June. And like I said earlier, we're just in the process of getting communications online to be able to help residents better understand the income thresholds, what it means for them. We also have, like some of you may remember, that we had a calculator that was online that residents could access while we were going through the engagement process to better understand the impacts on their individual families. And so we've now updated that calculator in line with the thresholds that are actually will be in place for this coming year to give folks a better understanding of the impacts for them. So, yep, and I think that's the next slide. Communications, and I just spoke about this. We're in the midst of getting those communications out. And yeah, that is the status right now. Things are still on track for September 1st. And with that, Madam Chair, that's the end of my presentation. So open to questions.
Thank you for the presentation. I will now ask the members if they have any questions. We'll start with Danny, MLA McNeely.
Thank you, Madam Chair. Because this is a new revised program, consultation is very important. I'm just wondering, my question to you is, the regional wellness councils, are they going to be involved with staff to do community by community consultations? Take the Sahtu, for example. Are they going to go to each community and have a one-on-one to help better understand the public to this new policy? Thank you.
Thank you, Madam Chair. So the consultation process has occurred, and it's been like a 2-year process, I would say, and there were a number of like public engagement sessions as well. Just recently, I did meet and do a presentation to the Leadership Council, which is representation from the regional wellness councils, and so they, and prior to that, they had also been part of the engagement process. At this point, there's no further engagement plan between now and September, but there is always opportunity for residents to give feedback and to ask questions about the process through the implementation process.
Follow-up?
Thank you, Madam Chair. That still doesn't answer my question here. I receive, and I imagine all MLAs receive a lot of phone calls about social programs. And if the regional wellness in the Sahtu can go to each community, I think that might minimize my phone calls. For example, in the community of Cove Lake, they haven't seen an optometrist for 2 years. There's public residents going around with snare wire on their glasses. And so because of that, I do receive a lot of phone calls. So this will help educate the new program. When's it going to kick in? So I just see a lot of value, and that's why I asked that question. If the regional wellness councils, it's a co-management structure to deliver health care. So we got our TWC and our RWC. But if I asked John Doe downtown Delaney, who's the chair of the Regional Wellness Council? That's the organization to speak on your behalf at the regional level to engage on efficiencies of healthcare. They're probably going to say 9 times out of 10, I don't know what you're talking about. So I see a real gap there. So this will be one way to fill the gap. I'm just encouraging you to go to the communities and have the Regional Wellness Council with the staff help educate this September 1 startup of this new program. Thank you.
Thank you. Ms. Matheson?
Thank you, Madam Chair, and that's some great feedback, and we will definitely take that consideration in our communication planning here in the coming months to see how we can get that information to the regional wellness councils either through the Leadership Council or directly. I would just remind too that many residents in the communities may not understand that they are not impacted because it doesn't apply to residents who are accessing non-insured health benefits. So most of the residents in the communities are eligible for non-insured health benefits, and sometimes that's the confusing part, which I can see where it would be helpful to help make sure that people understand that if you're eligible for non-insured health benefits, you don't need to worry about these changes because they do not apply to you. And even that message there and making sure that's clear, and we did hear that in the engagement, actually in engagement that we had with the Leadership Council most recently. And so I've talked to my team, and one of the main things we're going to have amongst leading all communications is around this applies to you if, it does not apply to you if you're eligible for these other benefit programs. So, but yeah, thank you for the suggestion, and we'll definitely work to incorporate that.
Thank you. MLA Reid?
Thank you, Madam Chair, and thank you for your presentation. My first question, and I might have a second question follow-up. When you spoke about the maximum would be 4% of the income, can you clarify if that was net or gross? Thank you.
Thank you, Madam Chair. It is net income.
Okay, Ms. Madison? I apologize.
Sorry.
Ms. Reed, MLA Reed, do you have a follow-up?
Thank you, Madam Chair. Thank you for that. That's slightly more comforting. And I did hear in your presentation also that you've updated the calculator. I'm assuming that's publicly available. Is there further work that can be done, and maybe you can outline the timeline a bit better about the public communication piece of these tools and these changes, so that more people can understand their own particular situation a little bit better? I'm hearing a lot of, I don't want to say fear, but definitely concern from folks in the pharmacy organizations here in town, folks from NGOs here in town, and people are in a bit of a state of panic the closer we get to September 1. So if we can maybe help people see what their actual picture will look like, we can better help them advocate and find solutions. Thank you.
Ms. Matheson?
Thank you, Madam Chair. Yeah, so the timelines on the communications are imminent. Like, we want them out in April. Like I said, I believe they're currently with translation right now, which is just the thing that we need to get them French and English so that we can put them online. But the calculator is ready, and it's been tested, and I have in front of me the signed off threshold documents, like that kind of lay out what the family deductibles are, what the family maximum. So those things are ready to go, and they're with translation right now. So like by the end of April is when we're hoping to have this stuff online. So, but totally take the point. We want residents to see themselves in this and to be able to figure out what that means for them. And, you know, many residents also have employer insurances, and they want to better understand how those employer insurances help to cover off, because the EHB program, the Extended Health Benefit Program, is a payer of last resort. So many residents are already accessing their employer insurances first. And so it's any residual that's not covered through employer insurance that could be picked up by this Extended Health Benefit Program. But more importantly, even, not more importantly, but as important, is those people that are currently don't have benefits and now will get to have benefits. So they're the ones that, you know, they're the ones that will get to see some benefits come September 1st. Thank you, Madam Chair.
Any more questions? George, MLA Nurse.
Yeah, thank you for your presentation. Educating the general public in these changes is very important. In these smaller communities, they have CHR workers who work with the community in general. Would they be able to give this information out? Thank you.
Ms. Madison?
Thank you, Madam Chair. So it's a good suggestion, like as for how much information to share with like health professionals in general, to be able to share with the clients coming and accessing health services. But we can take it under advisement to determine how we could do that, like just to make sure that more of the professionals working within the system have information at their fingertips to be able to provide residents or direct them to the right spot on the website. Thank you.
Follow-up?
Okay, thank you. Yeah, just my concern is I don't think everybody walks around with their previous year's taxes, and you know they may not be aware of this. So be good to, like in Fort McPherson, we have a radio station that's used by all the organizations, and that's someplace where this message can be given out, but other communities, you know, the residents may have to know these details before, or if there's a database where they can actually provide this information prior to, you know, even needing it. That way, you know, you're saving time. Thank you.
Ms. Matheson?
Thank you. Yeah, we understand that providing the income information, the tax information may be challenging. We're trying to get enough information out soon enough, for sure. But again, it does come back to, and also making sure that people understand that residents that are accessing non-insured health benefits, they do not need to go through that income assessment process, right? So that is also just always keeping that front in mind, that many residents currently accessing, the change is not going to affect them in the communities. But point taken around making sure that the information is out soon enough, that not everyone is going to have handy access to their income information, and that may need support and guidance in getting that information. Thank you, Madam Chair.
Okay, thank you. MLA Morgan?
Thank you, Ms. Chair. So it sounds like a big impetus or reason for this change was to save some money or control costs. Have you done some quantitative analysis to show that there will be cost savings under the new policy versus the old policy? And if so, where can we see that data?
Ms. Matheson?
Thank you, Madam Chair. So we have done some analysis. It's challenging to do the analysis when it's not really clear what the health needs of residents are going to be. But based on data that we had available for the analysis, we estimated that with the uptake on those now accessing benefits that hadn't previously, as well as the income assessment piece for those that were previously accessing that will now pay a portion of that, that we were going to break, it was going to be fairly like break even. There was like a plus or minus like $500,000 either way is what we are currently estimating. We have a plan for monitoring and evaluation of the costs and the uptake, like where the costs are coming from. And so we do plan to monitor that. In addition, there's a lot of work that's happening in the department to try to manage the cost of the drugs. The drug program is the main driver of the cost in the drug benefits are the main driver of the costs. And they're significant, and they're changing every day. There's more and more drugs coming to market. There's more and more, they're more expensive drugs. And so we're doing a lot of work to manage those costs, to make sure that while we're providing benefits to more people, we're also controlling the costs of the drugs that are being accessed.
MLA Morgan, do you have a follow-up?
Can you tell us, just for scale and context, like what is the current annual cost of the program, and maybe even you're saying that for a number of years you've been having to go and ask for supplementary costs. So even just like over a 5 or 10 year period to see how those costs may have changed to lead us to this point where we're at. And if you don't have it right now, would you be able to commit to provide the committee with that background info?
Ms. Matheson?
Thank you, Madam Chair. So the entire extended health benefits program right now the budget is about 13 million, and some change, 13 million. 9 million of that is for the benefits that we provide to seniors, and 4 million is for the benefits that's provided to those accessing because they have a specified disease condition. I don't have the history top of mind as to how that budget has changed like annually. But like in terms of going to the financial management board and getting more increases, but I can provide that. It's not always that we change the budget, is that there's supplementary funding that's provided to offset the costs. But yes, that's That's the high-level sort of budget numbers. Thank you, Madam Chair.
Thank you. MLA Testart?
Thank you, Madam Chair. I just wanted to follow up on the cost question because I appreciate that healthcare sustainability is a priority. But I think it's concerning that you don't actually know how much you're going to save through these changes. So what was the methodology? And if I misheard, please feel free to correct me, but what was the methodology used then to redesign the program towards cost cutting if you're not actually sure how much you're going to save? Thank you.
Ms. Matheson?
Thank you, Madam Chair. I'm trying to refresh my memory, but basically we took the current access to the program and we adjusted figures based on if individuals had to pay a portion of that, right? And what that would mean, how much would be left with the GWT, how much would be with the individuals. We had to do some analysis in terms of income levels of our residents, as well as age of our residents. And so we did factor that in. And we also wanted to make sure that the cost sharing arrangements were reasonable and as low as possible to still have some significance in this effort. And so those are the approaches that we took. We made some estimates based on the number of people currently not accessing benefits and what the average benefit access would be. But like I said, it's very largely dependent upon the benefits that someone needs. And so we don't know from year to year which drugs are going to be needed, which medical supplies and equipment are going to be needed. So it's very high level costing that was done, which is why the monitoring evaluation and ongoing, the monitoring evaluation framework on an ongoing basis is so important for us. And those are the commitments that we also made to the Financial Management Board, because we didn't ask for more money to change this process. We've kind of told them about the work that's underway and are committed to monitoring it as we go. Thank you, Madam Chair.
Thank you. MLA Testart, do you have a follow-up?
Yes, can you provide those cost estimates to, thank you, Madam Chair, sorry. Can you provide those cost estimates to the committee or do you have them today? Thank you.
Ms. Madison?
I don't have those with me today, but we can provide a summary of those estimates that were done, yes.
Thank you. No, yeah, second round, yes. MLA Hawkins, do you have a question?
Thank you, Madam Chair, and I appreciate the opportunity to ask a question. And I'm just trying to switch my screen here that has my question on it. There you go. I wrote it out while I was waiting. It's interesting, the information that was provided, I'm grateful for, and I want to thank the presenters for that. It was also interesting to hear that some of the challenges are built around the drug plan, and one should not ignore the reality that the federal government is now looking at launching a pharmacare program, and there in itself, it may be some of the solution for the changes. It was also interesting to hear the fact that, at the end of the day, the program may be a wash. So it's shifting responsibility in some ways. So I guess maybe my first question is there's a lot of work been done by the department to define the uncovered. So could the department be very clear on exactly who the uncovered is? Because if you've currently defined those who are Métis or NHIB, so in other words, if you're Indigenous or Métis, and in this case now extended to seniors, who exactly is uncovered? And when I say exactly, I would really like it to be clear on the record with respect to their age, their race, their ethnicity, their color, and any other types of things worth noting for clarity. Thank you.
Thank you. Ms. Madison?
Thank you, Madam Chair, and noted around the federal Farmer Care program that is, at some point, it's currently in discussion, and we don't have a lot of details on what that is or when that's going to be implemented or what the impact is going to be. So noted that, and that's a thing we will continue to keep our eye on. As far as the uncovered, I don't believe we'll be able to break it out in a very specific way, but for an example, it would be somebody, and it could be any age person, less than 60 at this point, that would be impacted, that would be working at a job that does not offer benefits. And so it could be a non-Indigenous person working at Walmart, and I don't know if Walmart has employer benefits, but it's working at a business that does not offer benefits or does not offer sufficient benefits. And those are, or someone that is not employed as well. Those are the people that are considered non-covered. Thank you, Madam Chair.
MLA Hawkins, do you have a follow-up?
I do, Madam Chair, and I appreciate the answer. I just kind of feel like it's not detailed enough, and I would like some further detailed follow-up, because the reason I say that is because my next question's about is if you must have the detail as to who is not being covered, and therein lies part of the next question, which is what is this extended group that wasn't being covered? How much would that have cost? Because I mean, that's got to come in the analysis of FMB to say that. So ultimately, if you know who you're not covering, you should also have an idea as to what that would cost. And I think that's critical to understanding the overall picture when we're considering so many unknowns still existing with respect to if the program is going to be a wash, the pharmacare is coming ahead. And so there's still many levers to pull and moving parts with respect to this. So thank you. I'd like to know that cost. Thank you.
Ms. Matheson?
Thank you. Yeah, and again, I don't know that I'm going to be able to give the detail, but we had estimated that it was about 2,200 people at the point that we started this exercise that were currently not covered because they were low income or because they were not Indigenous and covered under those other programs. And again, it's all those folks that do not have a specified disease condition that may just not have known to access the program. So for example, myself, like I would now be eligible to apply for the program, but because I have an employer insurance, I would access my employer insurance first. But if I didn't have this job, I would be eligible now, and I wasn't before. So it's all those situations, and it can change. It can change depending on the person's employment status or health status, as well as to family status. Like there's lots of things that come into play to determine whether or not someone will be eligible now that wasn't before. Thank you, Madam Chair.
Thank you. Thank you. MLA Yakalaya, you have a question?
Yes, thank you. Thank you for your presentation. And I was looking at that, and the question I had, well, the other members have some really good questions, and other health issues not on the list. I don't have the list in front of me, but the list must be, there must be something significant that is causing, well, there must be something else needed. That's why they're not on the list. So can you be clear and what are those illnesses that are not on the list? Thank you.
Ms. Madison?
Thank you, Madam Chair. And I don't have the list in front of me. It's a very short list, actually, of the specified disease conditions, but I may just turn the the mic to my colleague Stacy, Ms. Ridgely, to be able to provide a couple of examples of things not on the list.
Okay. Ms. Ridgely?
Thank you, Madam Chair. I can think of one example, a person who had a transplant. I think it was a lung transplant, and the drugs that were required to maintain the, what do you call that when you, non-rejection, were not covered. That is not a condition that is covered under the Extended Health Benefits Specialized Disease Conditions list. So that person didn't get coverage for those, and they're lifelong drugs that you have to take, and they're quite expensive. So there was that. There was other situations where the sort of weird idiosyncrasy around the specified disease list is that it's based on a diagnosis. So any medication that you would prescribe someone as a preventative drug, and I'm thinking PrEP, and that's the pre-HIV drug that can be prescribed for people, that could not be covered under extended health benefits because there's no diagnosis. It's a preventative medicine. So with the new policy, all the drugs on the drug formulary are covered for everyone, and it's just a matter of how much you may be required to contribute to the coverage of those drugs. So the PrEP drug would be covered. After your income assessment, and if you were using third-party insurance, then that would be covered. Those are two that I can just think of off the top of my head. Thank you.
Ms. Emily Akalaya, do you have a follow-up?
Yeah, and one thing you mentioned earlier in your presentation was that you had 2 attempts to change the this policy and you were not successful. And then you did do a review. Is the review complete? You did mention that there was a review done, but is it complete? That's my question.
Ms. Madison?
Thank you, Madam Chair. So yes, it was the engagement and the review, that's complete, and we're now at the implementation stage. But just to add to that, there's ongoing monitoring and evaluation to determine, whether there's any tweaking that needs to happen in the coming years, just based on uptake and based on costs, et cetera. Thank you, Madam Chair.
Thank you. I do have a question too as well. You said low income and there's, income threshold. You mentioned that. And you just gave a scenario of yourself, the eligibility. So will this apply to GNWT retirees with good income or with good pension? Will they be eligible for this? Because we know housing has different threshold, and income support, and this as well. So I'm just wondering, will you be eligible if you have a good pension? Thank you.
Yeah, thank you. So currently, under this, come September 1st, anyone that's over 60, they're still eligible for extended health benefits. So I'm assuming, retired GNWT employees, let's assume they're over 60 with good income. So yes, they would still be eligible. They likely have employment benefits and pension, whatever benefit packages that they have when they retire, those would still be accessed first. So this program is a payer of last resort. Yeah, and just the thresholds that I spoke about, just to give some context to it. So the low income threshold and it's for 6 different regions. So in the Tlicho, it's for anyone that's making less than $30,000. And over in the SAT2, I believe it's anyone making less than the assessed of $37,000. So it's quite a range depending on the region. And the high income is $200,000 in Tlicho and SAT2 is $245,000. So there's a range of bands. There's 30 different bands in between there. That just to give you a sense of what those threshold levels are.
Yeah, thank you. Thank you for the information. And I was going to ask about the specified disease condition. Ms. Emily Yakalai mentioned that, and then I think you gave one good example of it, lung transplant. So will this also apply to kidney transplant as well? Thank you.
Thank you, Madam Chair. Yes, it's for any drug that's on our formulary for any condition. Like residents with any condition for which their drug is on the formulary are eligible to apply. After they've exhausted their employer benefits, they can then access this benefit program.
So we're up for second set of questions, and MLA McNeely, and followed by MLA Morgan. Thank you.
Yes, thank you, Madam Chair, and you already answered my question on the threshold dollar figure. And I was going to ask that question and also provide a comment. It seems that the efficiency of the health delivery is improving. This is an example. And the other example for me personally is the advocacy group. So you got an advocacy group that wasn't there 10 years ago, but it's now. You got a couple of offices here in this community as well as other communities to advocate and navigate for the clients out there. And I think that's a huge improvement. And I also think that that there's room for further improvements, not to be a critic of the healthcare system, but to expand on efficiencies. Yes, I know we live in a high operating area and a very costly one with limited amount of funds coming from our Ottawa transfers. But I can also see why the budget is extended and appropriations are needed. So if we can come up with efficiency practices such as this program, we can do the same thing for strengthening healthier communities, and that would lower the cost. I'm very surprised here, but in some ways not surprised. Under the encouragement of one of my colleagues, and in preparation for this addiction workshop coming up here at the end of the month, the air ambulance transfers, just for the SATU only, for 21-22 was 125 flights. 22-23, 185 flights. Divide that by 12. 23-24 fiscal year, 138. So it tells me you got a huge problem, Mr. Satu. And if we can work in collaboration, which I really look forward to doing that over this term here, see how we can reduce that. If we reduce that by 50%, we not only save a bunch of capital, but we're building healthy lives. It's showing in the reduction of flying and medevac going to the capital for a number of reasons. I see that as a compliment. I look forward to working with you. That's it.
Ms. Madison?
Thank you, Madam Chair, and I appreciate the compliment. Well, I agree, and we agree, there's lots of work still to do. There's lots, and we realize we want to be as efficient as we can be. So noted, and we're working hard to try to do that, and we'll continue to reach out and hear from those councils for ideas and suggestions, so for sure. Just to circle back a little bit, one of the things that we're hoping that these changes do is does allow more people to access benefits that they didn't have previously, particularly in the prevention side, so that we can help those residents before their conditions get further along, and then they require those medevacs and those sorts of things. and I'm not trying to be naive about that. I know that it might not be that simple, but it's like every little bit helps. And this group here at this table is working hard on things medical travel related. So we know we've got a lot of things there where there's improvements needed and better communications and better administrative processes, et cetera. And so point taken that, recognize there's more work to do for sure. Thank you.
MLA Morgan.
Thank you, Mr. So when you talk about cost sharing for those who are above the low income threshold, is there a set amount of cost sharing, or is it kind of sliding scale depending on where your income is? Does the percentage of cost sharing vary? And secondly, is there a cap on how much the benefits will pay? You said there's a cap on how much a person should be spending, or their family will spend on drugs or any of the drug costs. It would be 4% of their net income. Is there a cap on how much the government is willing to contribute to any single person or family?
Ms. Madison.
Thank you, Madam Chair. So there's no cap on what the government will pay, assuming that the drug is on the formulary, et cetera. But I just want to give you, it'll be nice when we can get these online and folks can see the thresholds and work with the calculator. But I'll just pick one along the middle of the threshold, so halfway through the band. So there comes a point where there's a family deductible that's required. So I'm going to look at band 15 as an example, and we'll stick with band 15. So the family deductible is $620. So families would have to pay $620, and then they are accessing benefits. And the most that they would have to pay, so for each drug purchase, for example, they would pay 30% of the drug cost, and the government would pay 70% of the drug cost. And they would continue to pay 30% until at band 15, they paid a total of $930. So at that band, at no point would that family ever pay more than $930 for the drug costs. The government will be picking up anything on top of that. And so the next band is just a little bit more and a little bit more and a little bit more. So I hope that helps with some of the understanding, but those are the kinds of things that when we have the calculator available, like imminently, you'll be able to put that in there and see those numbers. Thank you, Madam Chair.
Thank you. MLA Morgan, do you have a follow-up?
Thank you, Ms. Chair. And so you've mentioned drug costs. Number 2 on your list there was medical supplies and equipment benefits. Now, I know I have families in my riding, for example, with children with long-term conditions or disabilities who need to purchase various supplies or equipment to, equip their home and other things so that they can live there properly. Is there a limit on how much of their income families will be paying on that aspect, the medical supplies and equipment, or how does that cost sharing work?
Ms. Matheson.
Thank you, Madam Chair. I'm going to look at my threshold here for band 15 again. I'll stick with band 15. So if there's a medical equipment purchase that's necessary and your income falls within band 15, you would pay 25% of that equipment cost to a maximum of $500. So there are only 3 maximums in the medical supplies and equipment. You're either paying a maximum of $500, a maximum of $1,000, or a maximum of $1,500. And for any one purchase that falls below, you're paying 30%. And if you have more than one purchase, you would pay 30% until your total outlay equals $500. Thank you, Madam Chair.
Thank you. MLA Yakalaya, you have a second set of questions?
I did. I just so this presentation you gave us is something that it's going to be implemented anyways, right? You're going to implement it September 1st. And so anything we have here is not going to change anything. And for the question of MLA McNeely had was, the consultation process. You said you consulted with the leadership, the leadership committee. I think like the people need to be consulted about stuff that's going to be affecting their lives, and the regions people need to know what is going on with stuff like this, so they're informed about what's happening. So consultation is very important. So I just wanted to reiterate what MLA McNeely said. It's important because, like he said, there's not a lot of people that know a lot of things that are going on in the health field and the health and the benefits that could impact them and their lives and their families. So the department needs to do more to consult with the regions, not just in people in Yellowknife know what's going on, but the regions need to know. Thank you.
Ms. Madison?
Thank you. Yes, so this decision, you're correct, this was a decision of the last government and is kind of rolled into implementation. It was initially to be implemented April 1st, like I said, and we just hit a few snags with our third-party contractor in the administration piece. But in the last government, there was significant consultation. In fact, this was the project for which we have had the most consultation as a Department of Health and Social Service than any other project that we have done, because we knew of the sensitivities and of the interest from the residents of the Northwest Territories in this. We had done a discussion paper. We've had a number of direct consultations with interest groups. We did a couple of online sort of open forums for people to ask questions. We received a number of, we had a place online where you could ask questions and receive responses back, and all of that information informed the the policy that we have in front of us. But agreed, we still need consultation. We're still interested in hearing on how this is going as we roll it out, and we'll continue to listen moving forward. Thank you, Madam Chair.
Thank you. MLA Yakalayo, do you have a...
Yeah, just thank you, Madam Chair, and thank you for that response. Also, just note that not a lot of people in the communities have access to internet or have access to the computer. So always got to be mindful about that when you're dealing with the communities. So when people come to the communities, they set up in the hall and they do a consultation with the people, and people do show up. So the people that are concerned about health issues or health situations that are coming to the communities, that would be beneficial. So we don't have to get all these calls. Why is this happening? Why is this not happening? So the department needs to make sure that people are informed in the communities. That's what I need. That's what I wanted to say. Thank you.
Thank you. Ms. Madison?
Thank you. Yes, and we know that it's always a challenge to communication just generally in the communities and how best to get the message across. So always looking to improve in that area for sure. Thank you.
MLA Hawkins, do you have a question?
Yes, can you hear me okay, Madam Chair?
Mm-hmm. Yes, can hear you.
Okay, thank you, just making sure. It takes a second to get back online, there's a lag. So if there's approximately 2,000, my apologies, just because 2,000 people that were not covered prior for various and sundry reasons, and we can go into the employment at length or their status or whatnot, but essentially the department has said is they're non-Indigenous people, and the example was Walmart or unemployed. So would they not fall under the Indigent program of coverage anyway? And as such, wouldn't they be captured? And at the same time, wouldn't we be able to capture and understand what that costs? Thank you.
Ms. Madison?
Thank you, Madam Chair. And I'm going to ask my colleague, Ms. Ridgely, to speak to this.
Ms. Ridgely?
Thank you, Madam Chair. The indigent benefits is not a policy. It is an emergency fund that is used to deal with emergency situations. So it's not a consistent support for people with low income who have no access to an employer-sponsored benefit. We're trying to provide folks with low income with a suite of benefits that will provide the sort of important prevention, health promotion type supports. So when a family that doesn't have an employer-sponsored insurance program has a child with, an impacted abscess tooth, they don't end up at a merge. They can actually go to the dentist and have preventative dental treatments. So that's what we're trying to put into place to avoid these emergency situations where people, the Indigenous benefits are there for, sort of last case emergency situations. We want to put into place supports for people so that we can avoid those situations. Thank you, Madam Chair.
MLA Hawkins, do you have a follow-up?
Yes, just making sure my mic's back on. So thank you for that. I hate to sound old in the sense of, old. Short question here is built around the framing up of how I'll describe it. This issue was brought forward in my time previously, and each time all members unanimously agreed that this should be supported, health benefits should be supported to all Northerners. In other words, we didn't view it as this group or that group, we viewed it as everyone. And we knew that Métis and NHIB covered certain people. And now the department has extended it to seniors, which I think was said earlier was approximately $9 million. So that change isn't being saved anywhere. It's still a committed ongoing cost. So we're not really we're talking about fringe costs here, and which are still unclear to me. And given the fact that the pharmacy, sort of the pharmacare program is coming forward as a true and real initiative, timing is subject obviously to, in other words, whenever it shows up, but that's your department to work with your federal colleagues. My question is really built around, is the department following a policy set by FNB, which are a bunch of employees who are fully funded by health, dental, etc., on Northerners who don't necessarily fall under this capture of benefits? So in other words, those who have are telling people how to adjust the policy around and creating new gaps. Would it not be easier just to play this out in an additional 6 months, and in that time identify the true cost of what it is costing us from the gaps, clearly identify those who might be falling through the system, and finally find a way to extend coverage? And again, I can't stress enough, there was constantly unanimous support amongst all members, Indigenous and non-Indigenous, to support all Northern people in a way. So thank you.
Ms. Madison?
Thank you, Madam Chair. I'm old too, but a lot has changed, since 2003 when this was first getting discussed, and there was, not necessarily buy-in for the income assessment process and the opening it up. Drug costs have gone through the roof. The cost of living is the cost of the drugs, is really hampering the sustainability of being able to just provide benefits generally. And so I think there's more of an appreciation for that on the cost of providing these benefits solely on the government, when there are other programs and some people can afford to contribute. I think there's just a change in the understanding of that. And that's where I'd say things maybe are a little bit different from the times before when it's been brought forward is, yeah, like the work that we're doing on the drug program right now, it's like just to see that the cost of drugs that are coming from the new manufacturers, and those costs are going to be hitting the government like beyond the, I forget what number I said there, but pay level or the band 15, beyond that $930, there's still a significant cost to the government of providing the drugs that residents need. And the intention is that it's a small contribution where folks can afford it to help offset those costs. And to the second point around, can we just delay this 6 months and then see who comes forward? Well, it's delaying, but how would you know who's coming forward? Right, the question is, how would you then figure out who actually needed the drugs, who would come forward if there's nothing to come forward for? So I would challenge that I don't know that is a great approach either. But again, a commitment to ongoing monitoring and assessment of impact. And we won't necessarily see the impact on the residents' health in 6 months' time, but we'll know how much it's been costing us to provide the benefits that we are going to be providing come September 1st. Thank you, Madam Chair.
MLA Morgan.
Thank you, Madam Chair. So there is concern from some people, and you can tell us if you think it's warranted or not, but that some people will be falling through the cracks if they're not covered by NIHB, and if they don't fall under the low-income threshold. I wonder if you can comment on that, but also maybe walk us through, if someone does have access to some form of private insurance, how they would, I know in all cases, even now, the process is that anyone starts by trying to access as much as they can through private insurance. And so how long does that take? And then is it only after they've, gone through various, hoops and channels through private insurance that they can even begin a conversation with extended health benefits to see what else could be covered? Or if they get some sort of coverage under private insurance, but their private insurance is not capping costs at like 4% of their income, are they stuck with that deal, or they can then go to EHB to top it up? Or can you just walk us through the process of how someone tries to navigate private insurance and where EHB steps in, and how you would ensure that people aren't falling through the cracks somewhere or other here?
Ms. Matheson.
Thank you, Madam Chair, and I don't know that I can walk you through in detail the process, but this is part of the reason why we're a little bit delayed, is that it's our third-party administrator that sets this all up and manages it all for us. But there is so the application process would determine whether or not you're eligible for benefits and or what benefit band you fall into. And once you're assessed a benefit band, that information is provided to our contractor, who's Alberta Blue Cross. It's easier to say Alberta Blue Cross, but that information is passed on to Alberta Blue Cross, and you're given a card that says you're eligible for benefits, and Alberta Blue Cross then knows what benefit level you're eligible for. And then when you need drugs, you go to Alberta Blue Cross, and behind the scenes, they're doing that coordination of benefits with your other benefit programs. So it's not like something that you're doing, or the individual is doing on their own. The third party, Alberta Blue Cross, is supporting that effort. So I hope that helps answer the question. And to your first question around the concern about people falling through the cracks, I'm not sure I have a good sense of what you mean there, or if you have an example, but the understanding is that we don't believe people are going to fall through the cracks through this, but maybe there's something I'm missing. So thank you, Madam Chair.
Okay, MLA Morgan, you want to answer?
Okay, so just to confirm, you're not aware of any category of person that wouldn't be eligible for at least some level of coverage under this policy? There's no one that... Yeah, I'll leave it there with the question.
Ms. Matheson.
Thank you, Madam Chair. I am not.
Do you have any more questions? Okay, MLA Morse.
Thank you, Madam Chair. Yeah, just a few questions. I guess my understanding of this is that effectively the number of people, and to be clear, the only folks I've been hearing concerns about this from are people that are currently covered under the existing extended health benefits policy. And it's not entirely clear to me how much that concern is related to uncertainty versus what is actually going to happen. But my understanding is ultimately there's not actually a huge number of people who will fall into this higher income threshold that will become kind of co-payers under this system. So does the department have some analysis as to how much cost is actually going to be offset by this change? Like how much they're expecting they're going to be bringing in as a result of the change?
Ms. Madison?
Thank you, Madam Chair. I don't have that detail here with me, but we do have that information, and I think I committed to providing earlier, like a summary of where we did that costing to land on that net impact for this program based on new users and income assessment. So we can commit to provide that. Thank you, Madam Chair.
MLA Morse, do you have a follow-up?
Thank you. And I guess this is the other thing, I guess there's going to be a question of clarification in here along with the question, and that is just that my understanding is there's this maximum of 1,500, which strikes me as being quite small. I mean, I've talked to some constituents who are facing costs of $30,000 a month in drug costs. So if the government is paying the $2,850 and the resident is covering this 1,500, it just doesn't seem to me like this is going to make a very substantive difference to the cost the government is facing versus it is a substantive cost for the individual. So I'm just curious to hear the department kind of speak to that a little bit.
Ms. Madison?
Thank you, Madam Chair. It's true, like, I hear what you're saying, what's being said, sorry, about the impact, and that was the entire intent, was to make sure that impact to residents was minimized, because we understand, people's resources are limited. But again, it's around doing what we can to make our public system more sustainable as well. And even if that means incremental steps or tiny contributions where we can receive them, that was the focus here. Thank you, Madam Chair.
Okay, thank you. MLA Reid?
Thank you, Madam Chair. This might be a bit tangential, but I think it is pertinent to the conversation. Can you, and perhaps you don't have these numbers here today, and if you don't, maybe you can get them back to committee and MLAs. Can you speak to the cost of the third-party contract and that relationship with Alberta Blue Cross, please? Thank you.
Ms. Madison?
Sure, I don't have all the specifics here with me. We have a contract with Alberta Blue Cross. It's been in place now, I believe, for 5 years, maybe. It was done through our request for proposals process, and we have another year, I believe, on that contract, and so we'll be going out for RFP here in the next year or two. We pay Alberta Blue Cross a percentage of the fees, a percentage of the benefits that they administer on our behalf. And I guess that's the most I can get into detail in terms of the contract, the details of the contract at this point. But yeah, that's the extent that I can share right now. Thank you, Madam Chair.
Thank you. MLA Reid, do you have a follow-up?
Thank you, Madam Chair. So I assuming that that contract is robust and is a cost saving to the government versus our doing it in-house. That's usually the case for RFPs for very specific skill sets and specific functions. I don't want to walk the line between political questions for the minister when I'm speaking to her staff, but I just do want to leave you with a comment that I am concerned with the current climate of Alberta Blue Cross and some of the news stories that have been coming out from them. So I will be interested in seeing how your RFP goes forward in the next, I guess, 18 months or so. Thank you.
Ms. Matheson?
Thank you, Madam Chair. I think I'll take that as a comment.
Do you have any more questions? Okay. MLA Morris?
Thank you, Madam Chair, if there's time. Question about this. Have we compared what this new system will, how this new system falls within comparison to other jurisdictions? The context I'll give to this is something that a resident pointed out to me is, you know, if I'm losing benefits here, what's my incentive to stay when I could go somewhere else I'll be covered, or somewhere else where my cost of living is going to be lower? You know, it's a pretty common argument being made by residents these days is like, what is my incentive to stay in the NWT? So I'd be interested to hear, I mean, have we looked at what other jurisdictions are doing? Are we maintaining our competitiveness, so to speak?
Ms. Matheson?
Thank you, Madam Chair. Yes, that all of that work cross-jurisdictional review was part of the larger review that I spoke about that led us into the discussion paper and the engagement. And so the results of the review show that we're still very, we're providing benefits beyond what is being provided in other jurisdictions. So it's not not incentive to move away thinking that there are better benefits elsewhere, because that's not the case. Thank you, Madam Chair.
Thank you. Do you have any more questions or? Well, thank you for the presentation, and it's good to know a lot of good information. And I think our public that are listening, I'm sure they're probably, they would like to know more as well. And I believe they can reach out to their MLAs for more information or to contact you guys. I mean, to contact the Department of Health. Yeah, so thank you for coming. Thank you for the presentation.